field of pharmacogenomics. Okay, so we'll be moving straight now to introduction in the chat box. Just tell us where you're joining us from, your name, your profession, and then whatever else you want to tell us. Just your name, your profession, and the country from which you're joining us. Just put that in the chat box while we wait for other persons to join us. I want to see the amazing persons on this call. Just do that in the chat box. Let's see where you're joining us from today. Okay. Okay, great. I see Patricia Kamazula joining us again today. She was here with us yesterday. We're really grateful for your presence, Dr. Patricia Kamazula from the United States, Michigan. Thank you so much for joining us. Let's see more of the introductions in the chat box. Okay, I see Esam from Egypt. Esam, welcome, welcome, welcome to today's session. It's really great to have you join us. Okay, I see Tuba from Indonesia. Welcome, Tuba. It's great to have you join us. I see Chidima from Nigeria. Welcome, Chidima from Enugu State, Nigeria. I see Samuel from India. Welcome, Samuel. Welcome, welcome. I see Wanga from Congo, from GCR Congo. Welcome, Wanga. I see Ahmed. Ahmed, you didn't tell us where you're joining us from. I see Bhavani. Bhavani from India. Welcome, Bhavani. Okay, I see Hor Dua Hor from Pakistan. I'm sorry if I mispronounced that. I'm really sorry. I see Ahmed joining us from Sudan. Welcome, Ahmed. I see Bodawale. Bodawale is joining us from India. Welcome, Bodawale. I see Sarah. Sarah from Nigeria. Welcome, Sarah. Thank you for joining us. I see Sultana. Sultana is joining us from India. Welcome, Sultana. Welcome, welcome, welcome. Let's keep the introduction coming in. We're about 3 minutes away from the actual start of our webinar. Let's keep the introduction coming in. Okay, it's really great to see the diversity in the room today, like it was yesterday. Welcome, welcome, welcome. Let's keep the introductions coming in. We're almost at the hour now. Just keep the introductions coming in. Okay, great. I see. Okay, Ahmed. Ahmed is from. Okay, Ahmed, you didn't state your country again. M-Farm in pharmaceutical industry. Welcome, Ahmed. It's great to have you join us. Okay. Welcome, 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 everyone. Okay, while the introduction continues, we would move straight now to the webinar proper. And we'll just do some basic introductory formalities before we dive into introducing our amazing guest speaker for today. Again, good morning, good afternoon, good evening, depending on where you're joining us from. My name is Destiny Eloisa Ale, and I am honored once again today to be your moderator for the session. Of course, this is the second day of our pharmacogenomics webinar series 2025 with the theme Pharmacogenomics in Practice, Bridging Theory to Clinical Application. This webinar has been carefully designed to provide insights into the ever-evolving world of pharmacogenomics. And in today's session, which is titled Practical Case Studies Involving Secondary Findings, we will take a deeper dive into the real-world scenarios where pharmacogenomics testing uncovers additional and unexpected findings. Okay, we are privileged to have a very distinguished speaker in our midst today, an expert who brings a wealth of knowledge and experience from both pharmacy and genetic counseling. So I am very certain that the conversation we're going to be having today is going to be, and indeed, a robust one. Okay. Now, I would move straight now, without further ado, to introducing our guest speaker for today. While I do that, I would like us to put the reactions in the chat box. I want to see the excitement in the room. It is with absolute pleasure that I introduce our esteemed speaker for today, Dr. Jerry Nichols. Dr. Jerry Nichols is a pharmacist and a genetic counselor with a natural passion for pharmacogenomics. Jerry's love for genetics began in high school when she was first introduced to Punnett squares and Mendel's P's. While pursuing her bachelor's in biochemistry at the University of Missouri, she worked in a corn genetic lab, learning to isolate DNA and run PCR and southern blots. The experience was interesting, but solidified for Jerry that pursuing a career in genetics needed to include more interaction with people. Jerry went on to obtain a master's in medical genetics from the University of Cincinnati, and then spent 12 years working primarily as a prenatal genetic counselor before deciding to pursue her pharmacy degree from the University of Missouri, Kansas City. During pharmacy school, Jerry maintained her love of genetics and desired to combine her two careers. But with pharmacogenomics still in its infancy, there was no roadmap to follow. Jerry fell into retail pharmacy for 8 years until joining Mizzou's specialty pharmacy in 2023. In 2021, frustrated by the lack of local access to and knowledge about pharmacogenomics, Jerry formed her own pharmacogenomics consulting business, Gene Pharma LLC. It is her part-time consulting work in pharmacogenomics that brings her the greatest satisfaction, whether through more tailored prescribing for patients or through working with and educating other healthcare professionals about pharmacogenomics. When not engaged in the practice of pharmacy or genetic counseling, Jerry enjoys gardening, making soaps and other bath products, and hanging out with her family. So at this point, I would like to see the excitement in the house as I hand over the session to our very esteemed speaker, Dr. Jerry Nichols, who will guide us through today's topic, practical case studies involving secondary findings. Once again, thank you so much, Dr. Jerry, for accepting our invitation. The floor is yours now. Thank you.
Thank you very much, Destiny. And I just want to say I appreciate you and all of those that were involved in organizing this wonderful international webinar. And I appreciate the invitation to come speak about pharmacogenomics, which is, yes, definitely something I am very passionate about. And so what I thought I would do today is talk about pharmacogenomics from the perspective of a genetic counselor. I tend to look at everything in medicine and healthcare with kind of a genetics lens on things. And so I would like to talk about pharmacogenomics and secondary findings. Got to make sure. There we go. So I'm going to talk today about secondary findings that come up on pharmacogenomic tests, because that's something that as pharmacists, a lot of times we're not really thinking about. We're thinking about using the test to help the patient have better medication outcomes. But the fact is that there may be other things that are found that can tell us something about their health or risks to them. I'm going to talk about informed consent because that kind of helps you be able to address secondary findings so they're not such a shock for patients. I'm going to talk some about genetic conditions, and these are genetic conditions that are not at all related to medications, but genetic conditions that if you know about them, they may inform prescribing. I also want to talk about when genotype doesn't quite equal phenotype. So in other words, you have a genetic report before you, and what the patient tells you about their medications isn't quite lining up. So I'll talk some about what to think about in those situations, you know, what you might want to consider. I'll have some case examples in here, and if I have time at the end, I've got a few that are not so much a mix of genetic conditions and pharmacogenomics, but are really just more pharmacogenomics. And then, of course, at the end, I hope that these are the objectives that you'll be able to meet. And of course, I hope I inspire interest in genetics beyond medications and help you understand how to look beyond the pharmacogenomic report that you have in front of you. So before really diving into it, I just wanted to touch on genetic exceptionalism. I don't know if this is a concept that you've heard of before, but it's really the idea that genetic information is inherently different from other types of medical information or other types of labs that may be run, and therefore it has to be handled a little bit differently. And if you think about it, if you have a genetic test today, you can likely use the information from that test for many years to come. Whereas other lab tests like a CBC or an hemoglobin A1C, you know, you're not going to use one from several years back. You're going to repeat the test because it's not still going to be valid and applicable to the patient today. Excuse me. And kind of similarly, when you do standard lab tests, they are typically telling you about that patient's health at kind of a point in time. Whereas a genetic test tells you a lot more about potentially a patient's health long-term, but also can tell you things about patient's family members, for example. And you're not usually going to get information about a patient's family member from a CBC or a hemoglobin A1C. You know, they don't tell you about non-paternity. They don't tell you about risks of having children with genetic conditions or things like that. And so when it comes to any kind of genetic test, and I would argue that a pharmacogenomic test falls in this realm as well, it's really important to obtain informed consent from the patient. And of course, informed consent, as you likely know, involves talking about what risks are involved, what benefits are involved, and what the alternatives are. So with a pharmacogenomic test, you know, one risk you might think about is a blood draw. Somebody might pass out or have bruising on their arm. Although pharmacogenomic tests can often be done with a simple cheek swab or even a saliva sample. The benefits, of course, are that you hope to be able to better inform prescribing, have better medication outcomes and less likely to have side effects. And then the alternative is you don't do a pharmacogenomic test and you just do kind of standard prescribing based on accepted practices. But one of the other risks of a PGX test is that it can identify some kind of secondary findings. So non-paternity, a risk of a genetic disease in the patient or a family member, or, you know, other things like that. And so it's really good to talk to patients about the possibility of those findings so that if they happen again, it's not a complete surprise and they're a little easier to address later, but also to make sure the patient wants the testing, there's not somebody coercing them to do it, and that they understand that a pharmacogenomic test doesn't tell about every gene drug pair. It also doesn't tell about every gene because it's only looking at some very specific ones. Particularly if you're using a PGX panel, usually most labs are analyzing a dozen to maybe 3 or 4 dozen genes. So the information you're going to get is going to be limited. The NSGC is the National Society of Genetic Counselors, and they have a couple of definitions about secondary findings and incidental findings. The two are technically different, but the terminology of secondary finding and incidental finding are often used interchangeably. I myself use it pretty interchangeably. Essentially, secondary findings are those that are purposely being analyzed as part of the test, but they're unrelated to the primary testing indication. Whereas an incidental finding could be detected unexpectedly during the analysis, but it's also unrelated to the primary testing indication. And these are just, again, examples of secondary findings. So a familial relationship may not be what you thought it was. Somebody's father or mother isn't who they thought they were. Or maybe a person's parents are related by blood and that hadn't been previously disclosed. You could find a new diagnosis or predisposition for the patient or identify risk to their children. And I'm going to give you an example from something that happened early in my career as a genetic counselor and was really, I think, the first time I came across like a secondary.
Okay. Dr. Jerry?
Yes.
Yeah, sorry to interrupt. I think there's some messages in the chats about your voice being low. I don't know if you could.
All right, let me see. I'm going to try to just move my computer closer, so maybe I'm closer to the speaker, if that'll help.
Okay, yeah, I think that would help. Yeah, it's louder now. Thank you.
Okay. Yeah. All right, and I will try to just consciously talk louder as well. Thank you. All right. So what I'm going to address now is an example of kind of a secondary or incidental finding that occurred early in my career as a genetic counselor and was, I guess, kind of the first time I really came across it. So I was working in high-risk obstetrics. I spent a lot of time talking to parents about amniocentesis, which is a procedure where you're sticking a needle into the mom's belly, removing some amniotic fluid from around the baby, and a lot of times looking at chromosomes. So you're looking at skin cells that have been shed by the baby to see if there might be something like Down syndrome or some other type of extra missing chromosome. And I had actually 3 almost identical cases where the report came back showing that the baby had 46 chromosomes. However, one copy of chromosome 9 had what's called an inversion. So a small piece of the P arm and a small piece of the Q arm broke. They flipped upside down and reinserted. So all of the information was there. There were no genes broken. It was just in an unusual place. And this is called a pericentric inversion 9. It's actually somewhat common. 1 to 3% of the population has this inversion. And so it's likely that somebody listening to this talk today has this inversion, if not a couple of individuals. When I called the mothers to let them know, you know, the chromosomes, there were 46 normal ones. There's this one that looks a little different, but we don't expect it to cause any harm to the baby. All of the moms were very surprised. And they were very surprised because they then told me, you know, I told them that either them or the father likely had this inversion. It's usually inherited. And they told me, well, we've already had blood chromosomes and ours were said to be normal. We weren't told anything about an inversion. And of course, in each situation, my very first thought was, oh, well, maybe who she says is the dad isn't really the dad. So this might be an example of non-paternity, which is something that was always discussed ahead of time before doing an amnio, that was the possibility. But usually you think, oh, if you're only testing one individual, you're not going to identify non-paternity because you have nothing to compare it against. So it turned out that in each case, all of these couples had blood chromosome studies done previously related to infertility or recurrent miscarriage, and they'd all had it done through the same major lab in the US. So I contacted that lab, asked for copies of the karyotype, like the chromosome picture, so that my lab director could look at it. And of course, this lab wanted to know why. And when I told them about the fetus having this inversion, I was told in each case that one of the parents actually had the inversion. The lab just chose not to report it because they considered it to be a normal variant. So that was good news for the families. It also meant that non-paternity was not an issue. But this was an example of where doing a single test actually brought up concerns or ideas about the genetic makeup of other individuals, because those other individuals had had testing done. So the same thing could happen with a pharmacogenomic test. You may test a patient not knowing that their parents or their siblings had also had testing, and then they go compare those tests, and they could realize that some things don't quite match up. And that might be one way that non-paternity ends up getting discovered, even though that wasn't the purpose of the pharmacogenomic test. So what I have listed here on the left are incidental findings that are in the CPIC guides. My guess is that the lecture you all had before this, there was some discussion of CPIC, so that's the Clinical Pharmacogenomics Implementation Consortium, and they create guidelines on gene-drug pairs. When you go to the CPIC website and look at individual guidelines, each one of them has a section in it called incidental findings. Most of them, so especially for the CYP enzymes and even for some of the receptors or transporters like SLC01B1, they may say no known genetic risk or no known disease risk related to this gene. However, there are at least five, the five that I have listed on the left, where there is a disease risk to the patient. And so these are genes that are being looked at not just to talk about medications, but you may also need to talk to them or refer them to a genetic specialist to talk about their genetic risk. And then the genes on the right are often on pharmacogenomic panels. There aren't any CPIC guidelines currently about these genes, but they are kind of considered secondary findings. So I'm going to go through all of these before I move on to talking more specifically about genetic disease kind of unrelated to medication. So we'll start with the RYR1. This gene produces the skeletal muscle ryanodine receptor. And when you undergo anesthesia, if you have a variant in this receptor, it can cause the calcium channel, the calcium not to be released properly through the channel. And so that can lead to sustained muscle contractions and what's called malignant hyperthermia, which can ultimately lead to death. So knowing that someone has a variant in RYR1 means that you would generally avoid giving them succinylcholine, and you would avoid volatile anesthetic gases like sevoflurane or halothane. You would choose something else so that you don't put them at risk for this malignant hyperthermia. But the other thing that's known is if you have variants in RYR1, it can affect muscle development and muscle function beyond the time that you're under anesthesia. And in this picture, I've listed a lot of different conditions that are related to this one gene. So there are things called multi-mini-core disease, centronuclear myopathy, central core disease, late onset axial myopathy. So a whole host of muscular conditions that are inherited mostly, I think, as autosomal recessive. There are a few that are autosomal dominant. And so finding out a change in the RYR1 gene might make a diagnosis in someone who had previously gone undiagnosed, or it may indicate that they're a carrier and therefore could be at risk of having children with one of these muscle diseases. Typically with the muscle disease, there's onset early in life with static symptoms that stay, which would be muscle weakness and potentially motor delays. And then there are these dynamic symptoms that can kind of come and go throughout one's life in response to like heat illness, or you could have exercise-induced muscle breakdown and so develop problems that way. G6PD is another gene that's on a lot of pharmacogenomic panels, and it's on there not because it is a target of medications and it doesn't break medications down, but what glucose 6-phosphate dehydrogenase does is it helps the body deal with oxidative stress. And so if you take certain medications like dapsone, respiricase, primaquine, nitrofurantoin, they cause oxidative stress in the body. And so if you have a deficiency of G6PD, you can end up with hemolytic anemia, which can ultimately be fatal. There are other things that can trigger it. Infections can trigger this hemolytic anemia in G6PD, as can eating fava beans. And that's actually the first time it was recognized was back in Pythagoras' time, when it was noted that some people eat fava beans and they don't survive, and other people do, and they're just fine. So, you know, there was a thought way back then, there's something inherently different about people. So G6PD is a secondary finding for that reason, because you're identifying somebody at increased risk of hemolytic anemia, not just from medication. But it's also on the X chromosome. So if you had a male who had a pharmacogenomic test done, for example, and his report came back and showed 2 different variants, then that would be highly suspicious for 2 X chromosomes, or a condition called Klinefelter syndrome, where there are 2 X's and a Y. Now, this would be exceedingly rare, but is a possibility when you do a pharmacogenomic test. UGT1A1, this is a glucuronidation enzyme, and it's important to our functioning because it helps clear bilirubin. So if you have a reduction in UGT1A1, it's possible that you could have a condition called Guillain-Barré syndrome. So some individuals will have 2 copies of STAR6 allele for this gene, or 2 copies of STAR28, or they might have a STAR6 and a STAR28. And those individuals will make about 30% of the normal amount of the enzyme. And for them, most of the time, it's not going to be a big deal, but in times of infection, fasting, or in response to certain medications, it may cause transient elevations in bilirubin. Generally harmless, it usually resolves on its own, and so no need to do like a big workup. However, there are more significant variants in this gene that cause actual absence or almost no production of the enzyme. And that's a condition called Crigler-Najjar syndrome. And those individuals need phototherapy pretty much from birth, and they ultimately need a liver transplant in order to survive. Now, my understanding right now is that pharmacogenomic tests are mainly looking at like STAR6, STAR28, I think STAR81. They're not sequencing the genes, so they're not currently identifying those more severe mutations that would lead to Crigler-Najjar. But someday, I think we will be doing sequencing for pharmacogenomics. And so this would be another example of secondary findings that can be identified, either saying somebody's at risk for this Guillain-Barré syndrome or for Crigler-Najjar. And then, of course, for prescribing medicines, usually if you have somebody with this variant, you're going to avoid or change the dose of atazanavir or irinotecan and a few other medications. MTRNR1 is a unique gene because it's on the mitochondrial DNA. So instead of being in the nuclear DNA in the nucleus of the cell, you know, you've got lots of mitochondria in every cell, and each mitochondria has its own circular DNA, and that's where this gene resides. So what it makes is the 12S ribosomal RNA subunit in humans. But if you have a variant in this gene, it makes that 12S look a lot more like the 16S ribosomal RNA subunit of bacteria. And that's what aminoglycoside antibiotics actually target. So individuals who have these variants are at an increased risk of having hearing loss when they're exposed to an aminoglycoside because it's targeting the patient's own ribosomal RNA. These variants, or specifically the 1555A to G variant, occurs in about 1 in 500 individuals around the world. And it's a very stable frequency regardless of what ancestry is. This is also kind of a unique one because if you identify this variant in an individual, you have pretty well identified that all of their maternal relatives have this as well. And that's because mitochondria are maternally inherited. So without testing other people, without getting their consent, you're essentially identifying a risk in other family members. All right, and then DPYD is the final gene that has secondary findings or incidental findings within the CPIC guidelines. This one is actually the rate-limiting enzyme that catabolizes our uracil and thymidine into beta-alanine. So that's its normal process in our body. But if you're given a chemotherapy drug, a fluoropyrimidine, like 5-fluorouracil or capecitabine, DPYD is what breaks down or detoxifies those chemotherapies. And so if you have either reduced or absent DPYD enzyme, you're going to have a very hard time detoxifying these chemotherapies, and it puts you at significant risk. So we know that about 7% of individuals of European ancestry and about 3 to 5% of African ancestry have one loss of function allele. So they make about half the normal amount of enzyme. And because of that, if you give them a standard chemotherapy dose of these drugs, they have a 4-fold increase for either severe or fatal toxicity. And then a very small percentage of people will have complete loss of activity. And in those individuals, you shouldn't give them like a fluoropyrimidine at all, not even at a reduced dose. The reason this is considered a secondary finding is if you don't make DPYD, then you don't convert uracil or thymidine to beta-alanine. And beta-alanine is structurally analogous to GABA and glycine. And so this absence of beta-alanine may then lead to things like seizures, motor delay, learning problems, or mental retardation. Some individuals, though, can have absence of this enzyme and be completely asymptomatic. So through this testing, you may be identifying a genetic condition in a person, or again, that they may be a carrier of recessive condition and therefore at risk of having children with this condition. And just a little bit more about DPYD, because we talk a lot about pharmacogenomics and we talk about wanting to find medications that work well and don't cause side effects. The reality is that there's always a person behind the test. And in some cases, we're not just talking side effects, we're talking, unfortunately, death for that person. In the US, it's estimated that somewhere between 700 and 1,400 deaths occur every year. And because of this, and in the state of Missouri where I am, it's between 12 and 25. And those are numbers that I like to put out there because I have definitely come across oncologists who think they've never seen a patient die from this deficiency. And the fact is they probably have, they just didn't recognize that that was the cause. It was chalked up to, that's just, one of the risks of the medication, that's part of the toxicity. The couple on the left, Joanne and her husband, David McIntyre, he had a bile duct cancer that was successfully resected surgically. His physician, however, wanted to give him the max dose of a fluoropyrimidine just to make sure all the cancer was gone. And unfortunately, unknown to them, he had a DPYD deficiency, and David ultimately died a tragic death because of this. On the right is Dr. Kapoor from Canada, and he was diagnosed with a stage 4 colorectal cancer. He was actually given a really good prognosis. He underwent pharmacogenomic testing prior to being given fluoropyrimidine and was given the all clear. So he took a dose, and he went from being well enough to work to being bedridden, and ultimately lost his life about 3 weeks later. His family, after his death, decided to have whole genome sequencing done. And from the sequencing, they identified a variant in DPYD that likely caused the toxicity in his death. So what happened was the pharmacogenomic test that was performed on him, they only looked at 4 variants in the DPYD gene. And those, of course, are variants that are more common in Caucasians than they are in Asians, Africans, or other populations. And that's one of the issues with pharmacogenomic testing, is that a lot of what we know about the alleles are based on Caucasian populations rather than being pan-ethnic. So that's always something to keep in mind when you do a pharmacogenomic test, is if the alleles being tested are a good fit for your population. Okay, so now I'm going to go through the genes that are on tests but don't really have CPIC guidelines and are also considered secondary findings. So many labs will test for ApoE. There are 3 different common variants, E2, E3, and E4. And they test for these because individuals who have the E4 are likely to have higher levels of total cholesterol and LDL, but also may have decreased response to statins. And so for those individuals, a different cholesterol medication may be a better choice. The other thing, though, about ApoE is that not only does it tell a little bit about how what kind of levels of lipids patients may have, but it also informs their risk of Alzheimer's. So individuals with E4 have an increased risk of Alzheimer's. Those who have a decreased risk. The pharmacogenomics labs don't comment on Alzheimer's, at least as far as I have seen. But if you have patients who are savvy, who have maybe heard of ApoE before, or they go take their pharmacogenomic tests and start looking at the internet, they may identify, oh, I have 2 E4s, I might get Alzheimer's, and it may freak them out. Having 2 copies of E4 does not mean you're going to get Alzheimer's. It just means your risk is higher than the population risk. There are a lot of factors that go into the risk for Alzheimer's. And then these last 3 genes are lumped under thrombophilias, although I kind of would argue that MTHFR doesn't quite fit there, but it has been on the thrombophilia panel for a couple of decades now. Factor 5 and factor 2, of course, are involved in the clotting cascade. And so if you have variants in those genes, you may be predisposed to clots. And the reason that these are included on a pharmacogenomics panel is that individuals who are given oral contraceptives, hormone replacement therapy, medications that promote platelet production, like the Doptelet and Molpleta, those medications increase the risk of venous thromboembolism. And so if you have a genetic factor plus a medication factor increasing the risk of clotting, that could be problematic. There is some concern that have variants in MTHFR may also lead to increased clotting, but that's a bit more controversial. There are 2 variants, C677T and A1298C, that are actually really common. A lot of individuals will have 1 or more copies of variants in MTHFR. And for many people, this doesn't mean anything. But if you go to the internet, you will find that MTHFR is responsible for absolutely everything. And if you go to someone who works in genetics, you're probably going to get a lot of eye rolls when you ask about MTHFR. So here in the US, MTHF kind of sounds like you're cussing. And that's the response I've gotten from a lot of people that had never heard of it before. But again, if you go to the internet, it's been blamed for causing ADHD, Down syndrome, cleft lip and palate, cancer, spina bifida, depression, Alzheimer's, a lot of different things. As far as what it really causes, it definitely is a risk factor for neural tube defects or spina bifida in a baby. If you have severe mutations in the gene, so not those 2 common ones, but if you have severe mutations, it can cause very high levels of homocysteine in both the blood and the urine. And those individuals have high risks of cardiovascular disease. They may be kind of tall, thin, lanky, can have ectopia lentis, so some other things involved beyond just high homocysteine. Individuals who have the common variants in MTHFR might have high levels of homocysteine in the blood, but not to the same level as somebody with homocystinuria. But if you do have high levels of homocysteine, that may be a risk factor of cardiovascular disease or other things. MTHFR is often on the pharmacogenomic panels because of this concern that maybe it increases the risk of clots, but there's also some evidence that it may influence toxicity to methotrexate and 5-fluorouracil, and it likely actually influences response to antidepressants. The way that you address MTHFR is going to typically be by adding B vitamins. The biggest one you think about is folic acid, because that's what the methylene tetrahydrofolate reductase is processing. But a lot of other B vitamins are included, and I'll show you that on the next slide. And if you can fix this B vitamin imbalance, you might actually either decrease or eliminate the patient's need for antidepressants, maybe statins and diabetic meds, because it's all sort of interconnected. This is kind of the best visual that I have found that shows how these are connected. I don't know if you can see my pointer, but the folate cycle is on the upper left, the MTHFR gene right here. So that's what's processing folate, but B2 and B3 are also involved. B12 is involved. And if this cycle isn't working properly, you're not able to convert homocysteine back to methionine, so you get too much homocysteine in the system. Also, if this cycle is not working properly, you end up with problems down here in the tetrabiopterin cycle in producing serotonin, dopamine, adrenaline. And so a lot of things end up being involved in MTHFR. What I found is that the American Psychiatric Association, in their treatment guideline for depression, they actually address folic acid as a complementary or alternative treatment. So they recognize that individuals who have low folate levels are less responsive to SSRIs, such as fluoxetine. And if you can supplement them with the folate, it's sort of like it boosts the benefit of the SSRI. And so again, this is another reason for the MTHFR being on the pharmacogenomic panel, but then it may also tell you something about that patient's risk of maybe cardiovascular disease, maybe depression, maybe having a child with a neural tube defect. Okay, and this is my one final slide before I jump into more specific genetic conditions. So I think it's important with pharmacogenomic tests to understand that today we are talking to patients and interpreting the test based on what we know today. Things are probably going to change in the future, and we may have to go back and reinterpret these tests. All of the CYP enzymes have some natural function in our body. They don't exist in our body because we need them to break down medications. They exist in our body because we need them to respond to foods and pathogens and just normal processes. So CYP2C19 is an enzyme involved in, processing clopidogrel, omeprazole, a lot of tricyclic and SSRIs, a lot of different medications. So there's multiple CPIC guidelines. But the thing about CYP2C19 is it also metabolizes arachidonic acid. And the metabolites that come out of that are then involved in relaxing the vascular endothelium. So if you have less of this enzyme, it would make sense that you're not converting arachidonic acid, you don't have those metabolites, you're not having relaxation of the vascular endothelium, and it puts you at risk of high blood pressure. And that's what these researchers actually found in a small, very specific population, the HACA population. So it's something that needs more studying, but there may come a day where pharmacogenomic tests are telling us a lot more about patients' risks of high blood pressure, Alzheimer's, cancer, just kind of common things. Okay, so moving on to genetic conditions. And I've split this into 3 categories. This is just kind of how I think about it. This is nothing official. And in fact, I could even argue with myself about moving some of them from one category to another. So we'll start with genes as the target. And sickle cell would be like the perfect example of gene therapy. I don't even know how to pronounce Lovotobeglio gene autotomicel, but that is the name of the gene therapy for sickle cell disease. So essentially what they do is they take the patient's own CD34 cells, they insert a lentiviral vector in there that encodes a modified beta globin gene, and then place that back into the patient's bone marrow. And the patient's bone marrow then is able to start popping out hemoglobin A, and it is able to block the hemoglobin S, or sickle hemoglobin that's being produced, to block it from polymerizing, and therefore you have less sickling of the red blood cells. This is a treatment that's currently considered one and done, and considered to be a cure for sickle cell disease. Then you have spinal muscular atrophy and Duchenne muscular dystrophy that both use what are called antisense oligonucleotides. Those are single-stranded nucleotides that target not the gene, but the RNA that the gene is producing. So spinal muscular atrophy is an autosomal recessive condition that causes significant effects in the nervous system. It causes muscle weakening. In the most severe cases, these individuals do not survive very long after they're born. And it's due to mutations or sometimes absence of the SMN1 gene. There happens to be a pseudogene called SMN2 that produces short, unstable, non-functioning protein. But what researchers found is that they can make an oligonucleotide against the RNA from SMN2. It causes SMN2 then to include exon 7 when it makes the protein. And now you have a stable functioning protein that replaces SMN1 and essentially gives these individuals a better chance at life. The two drugs, nusinersen and risdiplam. Nusinersen is an intrathecal injection. You get 4 of them over a 3-month period, and then you have to get an injection every 4 months after that. So it is a lifetime therapy currently. And the risdiplam is an oral therapy that's taken on a daily basis. And then with Duchenne muscular dystrophy, that's an X-linked condition. The individuals, the Duchenne gene is on, or the dystrophin gene is on the X chromosome. It's a very large gene. So in many individuals, there will be a single exon that has a significant piece missing, or a major variant that causes the dystrophin gene to become truncated and non-functional. And so these males will lose function of their muscles. They end up in wheelchairs. It affects muscles of their respiratory system, so ultimately they can't breathe. And without treatment, most of them are not going to live past their early 20s. So they've created these oligonucleotides for very specific exons, so it depends on the patient's mutation, that they may be able to then target it with one of these through an IV treatment that's given once a week. And it is essentially is helping make a much more functional protein to preserve the muscle of these individuals. Now, in this case, the gene isn't exactly the target, but the gene is more of a consideration in treatment. There is a medication called anakinra. It's a biologic that blocks the IL-1 receptor, and it can be used to treat things like rheumatoid arthritis. It's used in some cases of gout. It can be used for hospitalized patients that have COVID. But it can also be used for individuals that have an inherited mutation or even a spontaneous mutation in the NLRP3 gene. So it can cause something called NOMID, which is neonatal onset multi-system inflammatory disease. And there's something else called SINCA. So essentially, these individuals have a lot of inflammation in their joints. They have these periodic fever syndromes. They may have skin rashes. But in this pathway of NLRP3, they have elevations of IL-1B. And so it was discovered that anakinra, because it blocks IL-1, is actually beneficial to use in these individuals. So anakinra is an injection that's given daily. Then there are people who have something called PIK3CA-related overgrowth syndrome, or PROS. They develop hemihypertrophy. So for example, one leg may grow much larger than the other. They can have vascular malformations, lipomas, epidermal nevi. This gene can also become spontaneously mutated in some cancers like breast cancer. And so there is a small molecule drug called alpelisib that actually targets the PI3K pathway. It will inhibit that pathway. So it's able to kind of regulate the signal that's trying to cause overgrowth, whether in a breast cancer or in an individual that has this PROS condition. So again, not targeting the gene, but it's targeting the pathway. And then cystic fibrosis is caused by mutations in the CFTR gene. So it's one that's supposed to make a transporter that sits on the epithelial membrane and allows chloride ions to go back and forth. But if it's faulty, then you either get no production of protein, or you get protein that can't make it to the membrane, or protein that just doesn't stay open. So ivacaftor is a potentiator. It's a drug that if the protein can get to the surface, ivacaftor helps hold it open so that it can properly work as a chloride channel. And then you have correctors, elexacaftor, tezacaftor, and lumacaftor, that if the individual is making a protein but the protein's faulty, it helps it fold correctly so that it can get to the surface. So it kind of stabilizes the protein. So some individuals with cystic fibrosis, if they don't make any protein at all, these drugs are of no use to them. But as long as they're making at least some protein, they can usually use one of these modulators. And to my knowledge, these modulators are used solely for cystic fibrosis because they're targeting the CFTR protein. So they don't really have a use in any other conditions at this point. All right, and then genes as a risk factor. So there are a lot of connective tissue disorders. The common ones are Marfan syndrome and Ehlers-Danlos syndrome. There's also something called Loeys-Dietz syndrome. There's mutations in FBN2, which is kind of similar to Marfan's. But all of these conditions, if you have a connective tissue disorder, you tend to have a higher risk, for example, of aortic aneurysms. So fluoroquinolones end up being a good medication to avoid in these individuals because fluoroquinolones, increase the risk of tendon rupture. They make it even higher in these individuals, as well as just causing muscle damage in general and potential rupture of an aortic aneurysm. You also would want to avoid vasoconstrictors, so decongestants, caffeine, triptans, because you don't want to cause rupture of an existing aortic aneurysm. There's a condition called MEN2, which is multiple endocrine neoplasia type 2. It's caused by mutations in the RET gene. So this is like a hereditary cancer syndrome. These individuals are at risk of different types of endocrine tumors, but one in particular is medullary thyroid carcinoma. And in animal studies that were done for the GLP-1 agonists, so drugs like semaglutide, liraglutide, also known as Victoza, Wegovy, Ozempic, the common diabetic and weight loss drugs, in animal models, they showed that they were more likely to cause medullary thyroid carcinoma. So there is a black box warning for anyone who has a mutation in the RET gene. They should not use a GLP-1 agonist. They should use something else. And then lastly, Alzheimer's. And I should mention, none of this is an all-inclusive list. These are just examples that I'm giving to kind of give you a flavor. So with Alzheimer's disease, there are a couple of relatively new medications on the market, lecanemab and aducanumab, that target the amyloid beta protein to try to keep it from creating those plaques within the brain. What happens, though, is these medications put patients at a higher risk of developing something called ARIA, which is amyloid-related imaging abnormalities. So they're seeing edema in the brain or potentially iron deposition in the brain that can cause swelling, can cause leakage of the blood vessels. And so individuals who have ARIA are at an increased risk of having disturbances in their gait, having bleeds, having seizures. If you stop the medication, usually it's reversible, but there is that chance of an irreversible damage being done or even potentially death. We talked earlier about ApoE4 being a risk factor for Alzheimer's. And so about 15% of people who have Alzheimer's disease have 2 copies of ApoE4. And they actually do recommend that genetic testing be done before prescribing this medication so that the doctor can have an informed discussion with the patient and the family about whether they even want to pursue these medicines. They can be helpful to the patient, but if you have an ApoE4, it also puts you at high risk, as you can see from this chart, a 64% risk if you have 2 copies of ApoE4 that you're going to develop ARIA. Whereas if you have no copies, your risk is about 20%. So just an example of where a gene is being taken into consideration as it may be a risk factor for the drug. Okay, so now I'm going to give you some actual real world examples of mine, patients that I have come across and how we have used their genetic information and talked about medications. So this was a 47-year-old Caucasian male who in childhood was actually worked up by endocrinology for cystic fibrosis because he had failure to thrive, he wasn't growing, he had recurrent pneumonia, questionable diagnosis of asthma. When they would do sweat chloride tests, because when he was a child, genetic testing wasn't available, his sweat chloride tests were always in the gray zone, meaning that they were usually in the 50s. And anything above 60 is usually considered diagnostic of cystic fibrosis. Anything below 20 or 30 is considered that you can probably rule it out. His was always in the gray zone. But by about age 5, he started to grow. And they decided that they really weren't worried that he had cystic fibrosis, discharged him from endocrinology. As an adult, he's had various health issues. So dehydration to the point that he's had multiple heat strokes. He's had GERD, constipation, diarrhea, borderline oligospermia discovered during fertility workup, venous thromboembolism, and some like minor clots, elevated liver enzymes, also kidney and gallbladder stones. So the reason I point out all these things he's had in adulthood is there was an article that came out a couple years ago where they looked at a large insurance database of patients who were CF carriers versus those who were not carriers. So these are not individuals that are affected. They are just carriers, which traditionally has been thought, oh, if you're a carrier, you don't manifest symptoms, right? They looked at these individuals for 57 different health concerns that are somewhat common in CF. And they found that for all but 3 of them, they were more common in the individuals who were a CF carrier versus those who were not a carrier. So based on this article, this patient wanted to have genetic testing done to see if maybe he was a carrier, maybe that explained what happened as a child and some of the stuff he's dealt with as an adult. The first test that was done was a gene panel of CFTR, where they looked at only 106 mutations. And I say only because there are more than 2,000 known in this gene. But these 106 will account for probably 95% of the mutations. So they're the vast majority. Even though there's lots of others are not being tested, the other ones are much more rare. His test was negative. He wasn't satisfied. So he went on and found a lab that would do sequencing for the CFTR gene. And when that was done, he was identified actually as having a splice site mutation. So that splice site mutation caused the protein to be truncated and non-functioning. But of course, he presumably has one working allele because only one mutation was found. So this was a pretty satisfactory finding for him and felt like that's probably explained what had gone on through most of his life. Now, that information wasn't used for his medications, but for his sister. His sister, who's a few years older, she never had any of these other symptoms that he had. There were no concerns in her childhood of cystic fibrosis. But as an adult, she developed diabetes, and her doctor had recently put her on Ozempic. She complained of significant nausea, some vomiting, some abdominal pain. She had gone back to her doctor, told the doctor she didn't want to take this medication. She wanted something different. And the doctor was like, oh, just keep taking it. Your body's going to get used to it. Those problems are going to go away. Well, one thing that we know about cystic fibrosis is that carriers have a higher rate of developing pancreatitis. And we also know that Ozempic poses a higher risk of causing pancreatitis. So the sibling did not have CF testing, but we know that she has a 50% risk of being a carrier just based on being a full sibling. And so she went back to her doctor with this knowledge that she might be a CF carrier, which would put her at higher risk of pancreatitis and even higher risk being on this medication. So her prescriber agreed that she could stop the medication. When I was working full-time in retail, so this is just an example that you don't have to work in a hospital, you don't have to work in a clinic setting. You can use this information in retail if you talk to your patients and take time to understand their conditions and maybe look into things. So this young lady came in for her annual flu vaccine, and on the consent form, she had marked something about chronic condition. And so I asked about it. She told me that she has Charcot-Marie-Tooth syndrome. And of course, having been a genetic counselor for 12 years before going to pharmacy school, I was familiar with CMT. I had had patients who had this condition. So I spent a little time talking with her about it. And she was kind of excited to see somebody in the pharmacy who knew what this was. And the reason she was excited was she knew that there were certain medications that could potentially worsen her condition. And so now she felt like she had an ally that could help her avoid those medications. So what Charcot-Marie-Tooth is, it's a type of neuropathy that affects the distal limbs, so the feet, the hands, the feet in particular. So it can cause foot drop. It just kind of causes some atrophy. You can also get deformities like hammer toe and so end up having a lot of difficulty with walking. And if you take neurotoxic medications, it can potentially make the neuropathy that you're dealing with even worse. So some chemotherapy drugs like vincristine and paclitaxel are definitely known to put these individuals at high risk, and even individuals that don't have CMT. But then antimicrobials like metronidazole and nitrofurantoin can also be neurotoxic, particularly if they're prescribed for extended periods of time, so like more than 14 days at a time. So she was occasionally prescribed antibiotics during the time that I worked in that pharmacy, and she would ask to talk with me just to verify that I didn't see, an increased concern with these medications. And then just a little bit more about the genetics of it. So it is a hereditary neuropathy. It's inherited as an autosomal dominant, a recessive, and an X-linked. When I was doing genetic counseling a couple decades ago, there were like half a dozen genes known to contribute to CMT. Now there's more than 80, which is why I did not list them on this slide. So it's a very diverse condition that has a lot of genes that can cause it. This case came from our pediatric endocrinology clinic. So I deal a lot with children who have growth hormone deficiency. And many of these children are going to be treated with recombinant growth hormone. There are a lot of options available that are either once daily injections or once weekly injections to essentially replace the growth hormone that the children don't have. There is another medication called recombinant insulin-like growth factor 1 or recombinant IGF-1, and there's only one drug currently available called mecasermin. It is a twice-a-day injection. It can only be given if the child is going to eat after the injection, because if not, they can develop severe hypoglycemia. So if they can't eat, they're supposed to skip a dose. The mecasermin is also like 10 times more expensive than the recombinant growth hormone. So like I said, recombinant growth hormone used very commonly. The other one, not so much, because it's reserved for individuals who either have developed antibodies against growth hormone, so they're not going to respond to it, or they have severe IGF-1 deficiency. So we had this young boy who had short stature, he had low muscle tone, he had developmental or gross motor delays, he had digestive issues. So just kind of the combination of problems that he had. He had also been sent to a genetics clinic, and they did whole exome sequencing on him. And the report that came back said he had a mutation in the IGF-1 gene, that it was an autosomal dominant recessive pathogenic variant is what the report said. So the endocrinologist looked at that and said, oh, okay, so he's got an autosomal dominant IGF-1 gene mutation. That means he doesn't make IGF-1. He can't respond to growth hormone, because that's what normally happens. The pituitary pumps out growth hormone. The growth hormone stimulates IGF-1. And then growth hormone and IGF-1 both contribute to the growth of bone and muscle and ultimately height. So the doctor tried prescribing the mecasermin based on the genetic test. The insurance kind of balked at that and said, wait a minute, why can't he have growth hormone? And that's where I got involved. So autosomal dominant recessive made no sense to me. And as I looked into it, IGF-1 is actually an autosomal, mutations in the gene are inherited in an autosomal recessive manner. So this child had one mutation, not two. Therefore, he had one functioning gene. It is true that if you have one mutation, you are probably shorter on average compared to the rest of your family, but you're not as short as if you had two mutations. And with one mutation, you've got one functioning gene, it'll respond to growth hormone. So ultimately, we were able to get this child on growth hormone. So a once-a-day shot instead of a twice-a-day shot, also considerably less expensive, so saving money for him and the insurance company. 6 months into therapy now, and his growth velocity has gone from, I think, about 2.5 centimeters a year to almost 5 centimeters a year now. So he is definitely responding to the medication. I also work with rheumatology patients. So this was a 60-year-old female I had with rheumatoid arthritis. She was a smoker, she was a diabetic, she had high cholesterol, she also had high blood pressure. Her doctor prescribed her a JAK inhibitor because she didn't want an injection. But when I started reviewing her chart, I saw that she had a factor V Leiden mutation, and JAK inhibitors while they are oral medicines once a day, it might be preferable to injections for some people. They have a black box warning for causing major adverse cardiovascular events, including clotting. Factor V Leiden is not specifically said to be a contraindication in this situation, but it's definitely one that I wanted to investigate before we okayed the dispensing of the medicine. So I called the patient. Unfortunately, I was the one giving her the news because she'd had the testing 6 months before. She did it because her elderly mother had had a lifetime of blood clots and was found to have a Factor V Leiden mutation. So the patient knew she was at 50% risk. She just thought the test results had never come back because they'd never been conveyed to her. So I got to give her that news. And then I spoke with her rheumatologist because the rheumatologist didn't know that this was in the chart. It was ordered by a different physician. And the rheumatologist agreed that probably a JAK inhibitor was not the best choice in this case. And so she was given tocilizumab instead. So she ended up having to have an injection. She'd had injections in the past. She didn't have a fear of needles. She just thought pills were going to be easier for her. And we will come back to this case in pharmacogenomics in a bit. Excuse me. This individual was in her late 50s, healthy. She was just interested in knowing if maybe she had an increased risk of cancers or other things. So we did what was called a proactive genetic test that looked at, I want to say 160 or 180 different genes. They are mostly genes that would predispose to cancer syndromes, to cardiomyopathy, arrhythmias, and then a few other things like Marfan's, hemochromatosis. So she did that test. She had a family history of cancer, but it wasn't one that was like particularly striking for a particular cancer syndrome. However, her test came back positive for a mutation in the CHEK2 gene, which then places her at an increased risk for breast cancer. But the CHEK2 gene risk is not on the order of like BRCA1 or 2, where you would recommend a prophylactic mastectomy. So in this case, mastectomy is not really recommended, but increased surveillance is, as well as chemoprevention being an option. Chemoprevention is most typically going to be tamoxifen. And the thing about tamoxifen is that it doesn't have great anti-estrogen activity. Rather, CYP2D6 has to convert it into endoxifen. And endoxifen has like 30 to 100-fold greater anti-estrogen activity than what tamoxifen does. Lucky for this patient, she not only had wanted this proactive genetic testing done, she had also wanted pharmacogenomic testing done. And so we knew from that her CYP2D6 was reported as normal, 3A4 normal, 3A5 also intermediate metabolizer. But overall, expecting that she can convert tamoxifen to endoxifen very well. So that was encouraging for her to know that if she wanted to take tamoxifen, she should have a good response to it. And the thing is, we don't really test endoxifen levels. So it's hard to know if tamoxifen's working, unlike a statin where you can look at lipids, or a blood pressure medicine where you can look at somebody's blood pressure. So here it's really good to know their genetic status. I had mentioned early on that I was going to talk a little bit about genotype and phenotype discordance. So there's a lot of things to think of. Genes do not dictate absolutely everything. So if a patient's PGX test doesn't quite match what you're seeing, it could be that they've got drug-drug interactions going on. Drugs can inhibit or induce CYP enzymes, so you may get phenoconversion. The patient might have problems with drug absorption because they're on a PPI. Maybe they've got something going on with their gut microbiome, so they're not actually getting exposure to the medicine. You also have to remember, like in the image that was on the slide before, most drugs aren't metabolized by just one enzyme. There's a lot of enzymes acting on them, and that drug may act on multiple targets. So most of our guidelines currently only address 1 or 2 genes per drug, but the reality is there's a lot of genes probably involved. Systemic inflammation. I see this with my rheumatology patients. When you have elevations in cytokines, a lot of times that is inhibiting CYP enzymes. So if you can treat the inflammation, then you're no longer inhibiting an enzyme. That level may rise, so that may change how somebody is going to respond to a medicine. And obviously kidney and liver dysfunction could play a role, as can inaccurate test results, which is what I'm going to talk about next. So there may be time where you want to retest someone because maybe it's been years since they had a PGX test. Maybe we've got more alleles on the panel now, or you may need to reinterpret a test. So sometimes the bodies like CPIC and PharmGKB or AMP will analyze alleles and reassign them. So a star allele that was once said to be a normal metabolizer, there might be more data available now where we say, oh no, it's actually an intermediate metabolizing allele. So you might have to reinterpret a test based on that. This is a study that came out a couple of years ago where they compared patients who had had panel testing, where you're looking at just very discrete changes in the gene, and then they took those same patients and did sequencing, where you're reading the gene from end to end. And what they found was that more than 10% of them actually had an additional actionable variant. So what you see here is that when the genotype panel was done, just looking at a few alleles per gene, all of these patients, for the most part, were star 1. Star 1 is default. So if you don't identify one of the alleles that you're testing, then you say, okay, well, they're star 1. They're normal. But if you could do sequencing and read the gene from end to end, what they found, and like I said, more than 10% of those patients, was that they weren't actually star 1, star 1. A lot of times they had one, if not two, variants that had gone undetected. And so instead of being normal metabolizers, they're actually intermediate, or in some cases, poor metabolizers. So that could explain a genotype-phenotype discordance. And this is a patient of mine that actually illustrates that pretty well. So I had a mother approach me about her 17-year-old daughter who'd been dealing with depression for years. She had had side effects from escitalopram and paroxetine. She actually responded well to venlafaxine, but then it kind of quit working for her. So she'd had a genetic test done in 2019. I got connected with the family in 2023. What you can see here is that most of her CYP enzymes were normal, with the exception of CYP2C19, where she was a rapid metabolizer. And the lab sorts the drugs, into green, yellow, red, green being used with normal precautions, yellow used with caution, and red, like generally avoid if possible. So you see that escitalopram was in red, but paroxetine and venlafaxine were both in green. The other thing that I noted was CYP2D6 is responsible for metabolizing a lot of medicines, particularly antidepressants, and hers was reported as normal. I had the benefit of knowing that the test was done in 2019, and in 2019, that's when a lot of labs started adding deletion and duplication analysis. So that was one of my big questions. Did they test for deletions or duplications of the CYP2D6 gene? Because this gene is very complex. It has more than 170 different alleles. And some of those are either deletions or duplications, or they're actual rearrangements with 2D7 or 2D8, which are like pseudogenes that are nearby. And as listed here, CPIC has a lot of guidelines related to CYP2D6. So I got in touch with the lab, and what I found out was they actually reanalyzed this patient's sample 9 months later when they added deletion duplication analysis. They reissued the report, but somehow the report never made it back to the patient. And so what we show here is that the patient actually wasn't star 1, star 1, she was star 1, star 5. And star 5 is a deletion of CYP2D6 that is somewhat common in Native American, European, and Sub-Saharan African populations. So it's an important allele to have on the test. It wasn't there the first time, so by default, she was assigned star 1. So she wasn't a normal metabolizer. She was actually an intermediate metabolizer of CYP2D6, which meant a lot of those meds from the yellow or the green column got moved to the yellow column, including venlafaxine and paroxetine. So now her genetic test more aligned with her phenotype. One question I had, though, was why the venlafaxine worked and then didn't, and I'll explain that. And so she was able to actually be successfully placed on desvenlafaxine. So children are a little bit different than adults. Their CYP enzymes sometimes are at higher levels than adults and sometimes are lower levels than adults. And so that's one thing that may have to be taken into consideration if you're working with a pediatric population. Our patient was a rapid CYP2C19 metabolizer, so she made more enzyme than the average person. But you can also see, looking at this slide, that CYP2C19 starts out much higher in children and it declines over time. Looking at this image from PharmGKB, you see that venlafaxine is primarily metabolized by CYP2D6, She's an intermediate metabolizer, so she was getting less metabolism through that, but she's a rapid metabolizer of CYP2C19. So she was able to push through to desvenlafaxine. And there's a lot of evidence that the efficacy of venlafaxine is based on having a ratio of more desvenlafaxine than venlafaxine. So you need this conversion to happen, even though venlafaxine has some active property itself. My theory is, as she was aging through adolescence, even though she was a rapid CYP2C19 metabolizer, she started making less of it just because she was aging. And then venlafaxine became less effective for her. So that's why we moved to desvenlafaxine. And like I said, she was successful with that medication. Okay, so now I'm going to revisit that rheumatoid arthritis patient that I talked about a little bit earlier. So a few other things about her. She had taken atorvastatin for her high cholesterol for many years, no problems. She developed blood pressure issues, so they put her on amlodipine 10 milligrams. And about a month or so later, she started having some upper body and shoulder pain that she thought was her fibromyalgia flaring up. So she went to see her chiropractor. That didn't really help a whole lot. The pain kind of persisted. And then about 4 or 5 months later, she had COVID, and they gave her Paxlovid. And of course, the ritonavir inhibits CYP3A4. She ended up with severe leg pain because no one told her, stop your atorvastatin and your amlodipine while you're on this drug. So she ended up with a lot of leg pain. Her PCP did blood work. She had elevated LDH and CK, so they stopped the atorvastatin. But in talking to her is when I learned that the pain originally started after the amlodipine was added, and amlodipine also inhibits CYP3A4. So I thought, well, maybe she's an intermediate metabolizer of CYP3A4, and the amlodipine hurt her a little bit, but the ritonavir hurt her a lot. She was really reluctant to restart a statin, so did pharmacogenomic testing. And surprisingly to me, her CYP3A4 came back normal. Her SLCO1B1, also normal, and that's the transporter into the liver cell that the statins go through. But her UGT1A1 had reduced function. So this is an example of where your CPET guidelines for atorvastatin, they really only address SLCO1B1. I, though, went to the PharmGKB, the literature, just trying to understand a little bit more about what was going on. And so you can see that normally atorvastatin does have a lot of metabolism through CYP3A4. And so it makes sense that if you block on CYP3A4, it pushes things this way to atorvastatin lactone. It's actually the lactone metabolite that is thought to be responsible for all of the myalgias, all of the muscle issues. So the fact that she had reduced function of the UGT1A1 makes me think that initially she wasn't going down this pathway a lot. Most of it was going this way. And so the amlodipine and then the ritonavir pushed everything this way, causing her muscle issues. So atorvastatin hadn't been a problem for a long time until we added more medications on. So again, just an example of where you can't just look at the report and look at CPET guidelines. You may have to dig deeper to try to understand what's going on with the patient. All right, I think I may have enough time to go through these last two examples and then take questions. So these are just kind of strict PGX examples. I had a patient who was very fearful of not just antidepressants, but fearful of all medications because of his experience. So for a long time, he knew that if he took dextromethorphan for a bad cough so that he could sleep, it would leave him feeling kind of groggy, hungover, have a dry mouth the next day. Well, in adulthood, he was put on semaglutide or Wegovy for weight loss, and at one point developed a cough, took a dose of dextromethorphan, and started having serotonin-like symptoms. So was feeling shaky, had a rapid heart rate, sweaty, restless legs, insomnia, just generally didn't feel good. Went to the ER. The ER doc said, that's impossible. You can't get serotonin syndrome from a single dose of dextromethorphan. Patient never took dextromethorphan again. 6 months later, though, a psychiatrist put him on escitalopram. Took a single dose of escitalopram, exact same symptoms, back to the ER, again told that can't happen. And even the PCP and psychiatrist said, no, that can't happen. But anyway, he didn't take any more escitalopram. So at the point he saw me, he was on alprazolam and hydroxyzine, but was really looking for medications that he could use long-term for anxiety and depression that weren't going to be risk factors as he aged for falls and for Alzheimer's or dementia or things like that. So that's why he came to me. And of course, we did a pharmacogenomic test. The very first thing that stood out to me, he is a poor metabolizer of CYP2D6. So essentially makes no CYP2D6 enzyme. With the cough syrup dextromethorphan, if you are a normal metabolizer, the half-life is like 4 to 6 hours. If you are a poor metabolizer, the half-life is 24 hours. So him feeling groggy and hungover the next day after a single dose completely made sense. And we know that semaglutide can boost serotonin, as can dextromethorphan. So now, knowing this poor metabolizer status, it really did make sense what he experienced when taking dextromethorphan while on semaglutide. So then we had to look at escitalopram. If you go to CPIC guidelines, escitalopram, it really only addresses CYP2C19, and he is a normal metabolizer. If you look here, CYP2C19 and 3A4 are the major enzymes in this conversion, but CYP2D6 is involved there. He also happened to be a 3A4 normal metabolizer. But the other thing we know about CYP2D6 is it's the one responsible down here for further metabolizing escitalopram into those inactive metabolites that ultimately get excreted. And escitalopram is excreted 80% changed. So the problem this patient has is he maybe was converting this to this other active metabolite, but he wasn't converting the inactives. So again, it made sense to me that he experienced what he did with just a single dose of escitalopram because everything was hanging out up here and not being excreted. The other thing is he had 2 copies of the S allele for the SLC6A4 gene, and that's the gene that creates the serotonin transporter. It's essentially what escitalopram or SSRIs are blocking on. So he had low expression, therefore you could easily block potentially all of the receptors and really boost serotonin. So there's some evidence that this gene is going to put people at risk for side effects from SSRIs. So ultimately, I made a few different recommendations. I'm honestly not sure what happened with this patient. He had used propranolol in the past for some palpitations and anxiety, and it had actually worked pretty well. So we did talk about propranolol being one option, duloxetine being an option, and sertraline, because it's not really metabolized by 2D6, but definitely start with a very low dose and be cautious because of the SLC6A4 issue. All right, and then this is my final slide. So this is an example of where it can be good to understand the order in which the patient's medications were prescribed, kind of what came before what, and what were they prescribed for. Because this patient was, I think, about 70 when we did her pharmacogenomic test, but her issues started in her 50s. She was taking 400 milligrams of ibuprofen at bedtime for sinus pressure. And said that was really the only thing working at the time. She did this for several months and then started feeling very fatigued, very weak. Her doctor did a CBC. She had low hemoglobin. They did an upper endoscopy and she had some GI ulceration, so she probably had some bleeding. They said, stop the ibuprofen, start omeprazole. She did that. Her hemoglobin recovered, and they unfortunately left her on omeprazole. And she even switched doctors, went through 2 or 3, and they all left her on omeprazole. So 10 years after that GI bleed, she had a spontaneous femur fracture. And when I say spontaneous, she stood up, heard a snap, and fell to the floor because her femur just literally snapped in half. Doing her genetic testing, I think, potentially explains all of it. So she's a CYP2C9 and a 2C19 intermediate metabolizer. 2C9 metabolizes ibuprofen. So she was metabolizing it more slowly, meaning it was of more benefit for her, but it also put her at higher risk for things like the GI bleed. The other thing is she has STAR2 in CYP2C9, and it's known that STAR2 is in linkage disequilibrium with CYP2C8 STAR3, which means those 2 genes are commonly inherited together because they're closely linked. So The lab didn't test 2C8, but there's a good possibility she has that STAR3 allele. And this gene, our enzyme, also metabolizes ibuprofen. So kind of a double whammy there. CYP2C19, of course, metabolizes omeprazole. So she's an intermediate metabolizer. She's breaking down omeprazole slower. She's getting a better benefit, but she's also at higher risk of side effects, including it interfering with nutrient absorption and putting her at risk of osteoporosis and spontaneous fractures. So again, can't prove any of this, but the genetics fit very nicely with the history of what happened in this patient. And I will stop there. Like I said, I hope that this gives you guys a flavor of genes and medications and how things can kind of interact, and how you can do a lot of really good for your patients if you kind of do a deep dive into some of this.
Amazing, amazing, amazing. Wow, thank you so much. I'm sure this has been knowledge packed. It's been so much of knowledge to get from here. Thank you so much, Dr. Jerry. Was so very grateful for the wonderful and very insightful presentation. You have truly deepened our understanding of secondary findings in pharmacogenomics. We don't have much time again, so we'll go straight right to Q&A now. So we would start taking questions now. I would like to see your hands. If you have questions, I would just like to see our hands. Just put your hands up now, so we can take the questions one after the other. If you can still type in the chat box, please do so, because we're going to be taking only a limited amount of questions. So, okay, I think I see Hari Raran. I'm sorry if I mispronounced that. Please, you can unmute and your mic and ask a question. Thank you.
Very good evening, ma'am.
Hello.
Hello. Actually, this we were talking about the PGX testing panel, right? A patient is tested for every other genes, or we'll selectively test for genes?
I'm sorry, say that again.
No, we do PGX, we do pharmacogenomic panel testing. So if I am a patient, I will do every gene sets, or we will do the testing for selective gene test.
Yeah, most of what I've come across have just been panel tests. So you're kind of at the whim of whatever lab you choose as far as which genes they have on there. Most of them are good about including all of the, well, maybe not all of, but most of the CPIC genes, in particular the CYP enzymes, but they may not include like the RYR1 or the MTRNR1, some of those more rare variants.
Okay. Is there any criteria to select which gene?
An advantage to select which genes are on there?
Any criteria rules like that?
I mean, personally, I would like to have all of the genes that are on the CPIC guideline, along with some of the others that I mentioned, like UGT1A1. I can't remember if there's, yeah, there are CPIC guidelines for that. But the SLC6A4, there's no CPIC guideline, but I find that useful for people who have depression. So yeah, if you can build your own panel, they say more isn't always better, but I find that having more information, while I may not be able to use it today, it might be useful in the future. So having it, I think, is beneficial.
Thank you, ma'am. Very informative lecture.
Amazing. Thank you so much. Okay, I think we have Ali Onimajesin. Ali Onimajesin. I'm sorry again if I mispronounced. Please unmute and ask the question.
Yeah, good afternoon from here.
Hi.
Yeah, so I want to look at this from the medical legal aspect. So what are the implications of pharmacogenetics on therapeutics and clinicians? You know, for example, you have made mention of instances where people have died as a result of having some genetic deficiencies and being unable to properly metabolize some drugs. So what are the legal implications of that? Because sometimes, you know, there are cases where you have to continue. You can't wait for the test results to be out. And now in that kind of case, maybe the person ends up using a drug that the person has a poor metabolizer to effect on, and that patient becomes worse, or in the worst case scenario, maybe dead. So how does that translate to the clinicians, to the field? So that's basically what I want to get. Is it not trying to now limit what clinicians can do? You get?
Yeah, and that's a tough one that hasn't, I think, been completely tested yet and sorted out. The DPYD is a very good example. So the woman that was in the picture, Joanne, she has become an advocate who goes to a lot of cancer meetings. She's contacted the FDA. She's very much trying to promote doing proactive testing. And so, you know, I personally think doing pharmacogenomic testing is great for everybody, even if you're not taking any medicines right now, because then you've got that information at the point that you need it. A lot of physicians have kind of argued that they don't want to order the testing because they're concerned that if they don't interpret it properly or properly prescribe based on the test, then they become liable for that. But the argument might also be if patients want the testing, they're going to get the testing, and potentially in the future, those prescribers are going to be liable if they don't do the testing. So it's hard to know right now. I know that there are countries in Europe, I want to say that maybe Australia and New Zealand also require DPYD testing before you can give a fluoropyrimidine, but that's not the case in the US, at least not across the whole country. There are definitely institutions who will do the testing ahead of time, but it's not universal. And so, yeah, that is definitely a concern for some prescribers, is what their own liability is going to be if they do or don't order testing and they do or don't, you know, address it properly. But I think it's something that all prescribers are ultimately, and pharmacists are going to have to become comfortable with.
Okay, thank you.
Yes, thank you.
Okay, we'll take the last question now. The last question, and I think that should be Baba. Please, you can unmute and ask a question, please. Baba Hamza. Baba Hamza, please unmute and ask your question. Am I audible, Baba Hamza?
You are, yeah.
Okay. I don't see another hand.
I will, if I could just say, I am happy to answer other questions offline. If you're on LinkedIn, connect with me there, send me messages. I may take a little while to respond, but I do eventually respond, and I'm happy to connect with any of you.
Fantastic. So thank you so much. I think we've gotten to that point where we'll have to draw the curtain for today. Thank you so much, Dr. Jerry. This has been great. It's been amazing. We are really deeply grateful for your generosity and your kindness, your dedication to promoting pharmacogenomics education globally. We're really grateful. Thank you so much. And we'll call it a goodbye for now.
Yes, thank you very much for the opportunity to speak with all of you. Thank you.
Thank you so much, ma'am.
Yeah. Bye.
All right, bye.